Hello.
Are we live? Yeah.
Welcome back. Loyal fans of the Health Tech Talk Show, welcome back to our second time in a row at Health. So we have a quick special guest for you. His team, it turns out, helped Melissa clear this space, kick everyone out of it. We are not in the media lounge. As usual, she has caused a lot of trouble.
And she also knows everyone here who works here, like from year
people-
to year. They remember Melissa.
Yeah, they came back and helped her out because she is nice and also scary. But it turns out this fine gentleman's team helped Melissa, who we already know on the Health Tech Nerds, helped Melissa move all of the furniture.
No, that is not true. They were just on the
Oh, no,
sorry, I
moved
lied.
it. They not only moved off the furniture, but then picked it up and moved it for her. And we wanted to acknowledge
that's
your
legit.
people.
Okay, I take it back. That's legit.
So yeah, it was like an infrastructure play here that happened, right?
Yeah. So introduce yourself quickly to our loyal fans. They have done manual labor to the point of earning a minute on the Health Tech Talk
Well,
Show.
I appreciate for having me here,
Which is
Kat
very
and Lisa. Thank you. So I'm Paul Yasmin. I love primary care. We just want to spread love here. That yes, primary care is cool. I don't know if you can see my shirt, but we want to make it top of mind for people, and bring a clinician perspective. Make sure that patients, primary care patients, know what's happening. And I'm obviously these days a founder of a company, and so I wanna have people think about how do we think about what does good care look like, and how do we look at it, measure it, evaluate, think about the people who deliver care. Yeah, that's kind of what I think
You have
about.
to also say the name of your company.
Yeah.
Just a hot tip for if you're
Hot tip.
out there promoting your company.
Yeah, I mean, I actually would prefer that
not.
more people looked into this whole space because we need a bit more competition. So it's not just about my company. I think it's about the idea that
But can you say the name of your company?
It's XBC.
Oh,
So,
SPC.
yeah, there you go.
I
Yeah,
was letting
you
him
got
do
it.
it. Okay.
No, thanks. Yeah, I appreciate you guys having me here.
Yeah, well,
Nice.
we appreciate you showing up. We appreciate your team very much. You guys are the best.
Yeah, have a good show. I will see you around. Catch you
Thank
later.
you.
Yeah,
See
see
you.
ya.
In a
Bye.
boot.
All right.
All right, now we have actual legitimate real guest.
Hey, probably this is a legitimate
Michelle
real guest.
Zimmerman from
All right.
Previvor Edge.
Michelle.
Hi, great to meet you.
This is yours.
Oh, this is for mine.
You could, I mean, you could clip it if you want.
No.
Well, who shares it? You guys share it. Okay, got it.
We're sharing his
You're
camera.
all set.
Okay.
Here we are. Hello.
Oh yeah, here we are. So yeah, introduce yourself to our 400 loyal fans.
Great to be here. Thank you for having me. I'm Michelle. I'm the CEO and co-founder of Previvor Edge, which is a clinical program designed to manage cancer risk, which is a mouthful. So what that means is, the three of us are sitting here, and if you ask the question, how do I know I'm doing everything I can to prevent and detect my cancer, our answers are going to be very different. And the problem is most people have no idea what their risk is for developing cancer, and therefore don't have the opportunity to take steps to either catch cancers earlier or reduce their underlying risk.
Mm-hmm.
So what does that look like? Because we all downloaded our data from 23andMe and threw it into sites that had no security when we were worried that 23andMe would sell it, and we gave it away anyway to find out what our cancer risk was. Like, what else is there that you're looking at?
Yeah, great question. So the first thing is to look at your cancer risk. You have to look at your medical history, your family history, your genetic predisposition, your lifestyle, specifically the lifestyle factors that the American Cancer Society has extensive evidence on, as well as your environmental exposure. And for us women, your clinical risk score for breast cancer, otherwise known as a tyrocusic. And so once you do investigation into all these things, did you get your hepatitis B vaccine? Did you get your HPV vaccine?
Yes.
You're doing excellent.
Yeah, so far I'm
Lisa
good.
is a champion.
Listen, I'm always, as you all know, I'm always trying to get free medical advice here on the talk show. So please continue.
Yes. So certain chronic diseases, obviously, do you have a family history? Do you have genetics, et cetera? We look at all that information, and there are guidelines around how that changes your risk. Do you have a first-degree relative who has colorectal polyps or got colorectal cancer? You should be screened 10 years earlier than when they found those polyps or when they had colorectal cancer. Do you have extremely dense breasts? Do you have a moderate red tyrocusic? You should get a breast MRI or get a mammogram and an ultrasound. So things like that. How many hours a week are you exercising? Is it 3?
0.
Oh,
Depends
on the week.
Today I ran around this building a couple of
Excellent.
times.
You nailed
looking
it.
for various parties last night. We ended up
walked
going
a lot.
away. We walked a lot.
And did they serve you fruits and vegetables?
No.
They did not help
But
you.
we did eat many small burgers.
Does that count?
If they were
No.
vegetarian.
No, they were not.
But that's the idea. Like, we look at the evidence-based ways that you would identify someone with an elevated risk, and then we put together an action plan. So we help explain to you, okay, if the average person has a 40% lifetime chance of getting cancer, which is really the summation of the lifetime risk for many cancers, for any of these cancers, do you have elevated risk? Why do you have the elevated risk? What do the guidelines say that we can do about that?
Sure.
And then we put that into action in a clinical model covered by insurance.
So that kind of leads us to like, who is your customer here? Insurance, employers, individuals. Say more about that.
Yeah. So I generally think if you want to do something new in healthcare, it's good idea not to piss anybody off.
Okay.
We are doing a great job.
Loyal fans. That is not correct. Everyone is mad at us at all times.
But yeah, I mean, ultimately, so the patient is the one who's getting the care. So you obviously need the end user to be interested in this, to want to be in a position to take this information in, because it's scary. Like, nobody wants to talk about cancer, right? And now we're trying to change the paradigm and say, okay, guys, you should talk about cancer today because you can do something about it. We can't prevent it entirely, but we can certainly do our best to catch it early, which is a fundamentally different disease.
Sure.
Or we can reduce our chances of getting it. And here are like evidence-based strategies. From a payer perspective, I'll say we're just in network like any other doctor's practice. We're billing standard E&M visit codes. And we've modeled it after these cancer prevention and detection clinics that are in academic medical centers. And so they do it at a small scale. We've just taken that model, built it out a bit more, and are scaling it.
Okay.
So the insurance companies, because we start with evidence-based in the medical policies, we're implementing the things they already said they want to implement under a model that they're familiar with paying. And then on the distribution, we've been in deep discussions with health systems. They don't have the service line. They have all the patients, and they own all the downstream services that patients are going to need. They own radiology. They have cancer programs. They have surgeons. And so for them, we can help them extend the care that they offer where they're not going to build this kind of program.
But in terms, I think my question would then be about the time horizon, because unfortunately, while that is absolutely the right thing to do for individuals and families and maybe some employers, like, what is the average, lifetime on a particular commercial plan? Like 14 months, less than that?
Yeah. This
8 months?
is obviously the big question is what is the health economics outcome over like a 3-year period, give or take. We got to do the study for our program, but the answer I always give is we are implementing things where in an individual intervention, somebody's already done the health economics outcome study because it's in the medical policies and the guidelines. So we're not inventing anything new. And so at a programmatic level, if we are literally implementing all the components are guideline driven and people have done those studies, then the outcomes, should be positive. So that was step one. And then what we don't know is what's the positive externality. Like if you talk to someone about their red meat in the context of cancer and they're worried about it,
Somebody is looking suspicious
I'll do
over
an
here.
easy one. Sunscreen. That's an easy one, right? Sunscreen.
Don't you feel like sunscreen is
Okay, she don't listen. Okay, everyone,
Okay.
America,
Okay, forget about sunscreen.
Do not take health medical advice from Kat about sunscreen. It's very good.
I have great skin. My skin is great.
You do have great skin. She does. I'm sitting right here. She has great skin.
That's not a skin. That's
you.
not. No, don't
I
listen
also-
to her. Wear sunscreen.
Okay, let's talk about sunscreen.
Sunscreen.
Yeah.
Wear it.
So red meat too. I just want to agree with you.
Yeah. But my only point is, let's say your friend, God forbid, just got diagnosed with cancer, colorectal cancer.
Yes.
Bueno.
Shit,
Not
it's
good.
not good. You come to the program and someone says, you're eating red meat like 5 times a week.
Maybe slow down.
Maybe slow down, cut it back to 4. You're going to do yourself a favor. You might think, you know what? Did I need that mini burger?
I
The
did.
vegetarian one. Like how many, right? And so that's what we have to see on the positive externality
Sure.
side is like when you connect the dots and give someone a very specific goal.
Right.
But that's not like the holy grail is, did I catch the cancer early? Did I reduce the chances of them getting cancer in the
Right.
first place because
Right.
somebody took some preventative action?
Right.
And over what time period?
Right.
How'd you get into this?
So I've been,
Oi. That's a good answer. Oi.
I've been building in like this tech-enabled service space for probably 15 years. But the inspiration really came from what I did before this, which was run a cancer genetics business in a company that spun out of Mount Sinai in New York and went public. And as part of the portfolio, we were offering germline testing or hereditary cancer testing on a preventative basis into health systems. And it became so clear that there was no time in primary care OBGYN to do a deep investigation in cancer risk. And then it also became clear that for patients who did get tested and found out they maybe had a BRCA 1 or 2 mutation or Lynch syndrome or something, who's responsible for them? That's multiple different cancer types. Exactly. And I was inspired by some of the clinicians I met who were thinking along the lines of like, maybe it's a new subspecialty we need. And so I saw it there. I myself carry elevated risk. We have a tremendous amount of family history of cancer. I've seen family members survive stage 4 pancreatic cancer.
Wow.
Crazy. And I've seen family members have cancer detected early because they were in a high-risk screening protocol. And so if you just like take a step back and look at how we manage cardiovascular disease and how we manage diabetes and how we manage thyroid disorders, it's not a binary event. We get involved before the acute event. So why is it binary here?
Right. Yeah. It's interesting. It's also an area that, even though some of the things you're talking about, like testing for BRCA 1 and 2, is very well understood. There's a clear connection. We know who should get tested, blah, blah, blah. Like, there's also a lot of things that have a lower evidence base that are out on the fringes there. So there's a lot of promise, but there's also things that are not fully in that like fully evidence-based, fully accepted space. So it's tricky because you may get lumped in unintentionally with a category that's not following those care guidelines.
Yeah, but here's the thing: we don't need evidence anymore.
Okay, this is not true. Don't listen to
I'm
all
not
that.
sure
No,
if anyone has noticed.
we need evidence.
Okay, so here's
Science is real.
So
Anyway, back to the point.
Understood.
Sorry, science
No,
is
no,
real.
no. Science is real. I'm of that camp, but people want to consume things because they believe. So here's how we addressed it.
Good. Okay, like that.
So the way that we addressed it was we say, okay, so the foundational program, evidence-based, scientifically rigorous, covered by insurance, and then people are going to come in and they're going to want things that we call under investigation. That's your multi-cancer detection test. That's your full body MRIs, other things that are going to come down the pipeway. And we talk about them all. And we will order multi-cancer detection tests and we will take responsibility for the findings. We will not order a full body MRI because there's non-cancer related findings, but we will follow up on all the cancer related findings. And we'll also explain it to them. This is what the test does. This is what the test doesn't do. There's no standard, but it's integrated already into the things that there is good evidence. And so we view ourselves as like filling the educational gap and the implementation gap for the things we have good evidence about, and being early adopters in orchestrating the things that we don't have good evidence about that people want that are available. And then helping either to build that evidence, but not have the patient be like, all right, I'm going to go get my healthcare here and then go consume this thing on the side
Somewhere
completely
else randomly.
unsupervised. So that's sort of how we bridge the gap.
Yeah, makes sense.
All right. Well, where are you? Like, how big are you? Who are regional?
Yeah.
Not? Yeah. What's
Yeah.
going on?
We were founded about a year ago and raised some money about a year ago. We just publicly announced that we exist about a week ago.
Nice.
Yeah, so new, and here we are, and
now it's on
grateful
the
we
world famous
exist.
Health Tech Talk Show.
Yes, this is going to move
Said world
the
famous,
needle.
that's fine.
Yeah, we're in New York, New Jersey, and Connecticut. So we've set up clinical practices. We got in network with Aetna, United, Cigna, and some of the Blues. And we've opened up sort of the consumer initiated model. There's a wait list. We're taking people off the wait list, so it can all be done digitally.
That's fantastic.
And then we've been in discussions with large healthcare systems for a little over a year
Nice.
about, doing a multi-year sort of collaboration there. So it's new, like very new.
Very new.
Very cool. Very cool. And then how are you coordinating with the additional parts of the patient's care team?
Yeah, also a great question. So we spent a lot of time thinking about where do we sit with primary care? Where do we sit with OBGYN? And we position ourselves as an extension. So for example, if the patient has no risk in certain areas, great. Let primary care, GYN do their thing. If there's an elevated risk and they need to be screened differently, we take that on. so that the primary care isn't responsible for implementing something beyond age appropriate guidelines, just the way a cardiologist or an endocrinologist does things for somebody with an elevated risk. So we view ourselves as again, that subspecialist where patients deviate from average, need something different than the preventive task force guidelines. And we take all that off their plate. And then obviously we collaborate with whether it's radiology or, you know, subspecialists in gynecology, oncology. We're a referral source back to them.
Got it.
And so on. But like,
it's like a friendly situation.
yes, we are trying. That's like the way we set it up. We got a lot of help from our clinical advisory board about, you know, people. The problem is not that we're not doing our job well. Though that could be a different conversation. The problem is that there's actually a need that hasn't been serviced, and we're trying to service the need with someone else who already has a job.
Right.
It's like asking somebody with a full-time job who's already overextended to take on another full-time job. And so we just need to build the clinical model to do the job.
Yeah. Yeah. I would. Interesting. So so you're here at Health because you just launched, but any other reason why you're here? Anything else you're doing? At Health?
Socializing, being on this
Socializing,
podcast.
being on the show.
No, I've been
You
in
mean a live internet talk show?
yes, live internet talk show, the best live internet talk
Live
show,
right now,
just to be
science.
clear. No, like catching up with people. Like I've been in the space for so long, probably like the two of you. Some things never seem to change. Some things change more slowly, and you just walk the halls. You meet so many people. The serendipity of it all. And as an early stage startup, it's like nice to get out of the office a little bit, the home office with the kids.
Understood.
Yeah, and there's some value in the serendipity.
Yeah.
Nice. Awesome. Well, thank you so much for coming on the show. We're excited to see what happens.
Yes.
With Previvor.
Keep us updated.
And yeah, awesome.
Thank you. Thank you so much.
Thank you. All right. Next guest is up. Thanks, Michelle. What happened?
Oh, we have a furniture mover. Another furniture mover. Come on over.
Furniture mover.
Oh my goodness. Have a seat.
Have a seat.
Oh my gosh.
A physician. Do you have any medical advice? We need help.
No, what's going on?
He's all no.
Generally, he's like, oh no.
I'm off the clock.
Just
right now.
kidding.
Just generally.
So I echo everything that she said.
Yeah.
I mean, I'm a lifestyle medicine physician as well.
Yeah.
So I do promote lifestyle
Introduce
changes.
yourself officially to
Yeah,
the
sure.
loyal
So
fans.
my name is Dr. Nathan, Parthiva Nathan. I'm a family physician, but I'm also an entrepreneur. So I have a telehealth company, and so I work with community health centers, and
Oh,
I
nice.
provide after-hours care for them. So when their
Love it.
clinics close
Oh,
from
that's
5
cool.
p.m. to 8 p.m., our company takes over, and we see those patients. So we do a lot of
Nice.
follow-ups on ER discharge, and
Nice.
Amazing.
People don't know it because you can't really tell, but we are in the art. We're in the the place where there is art, and also a sort of collaboration with the National Association of Community
Mhm.
Health Centers. So that's
Right,
that's
yeah.
the context around us
Yeah.
that you can't maybe see.
Right. Yeah, that's who I work with.
Yeah.
Fantastic. And you're here at Health to
Yeah, so
hang
I,
out with us.
yeah,
move
so, so one of
furniture.
the clinics that I work with, I also do a lot of consulting work with them.
Nice.
So they wanted me to come in and look at AI solutions as well.
Fantastic.
I also have an AI company as well called Physician UX. It started up as a company just to improve the user experience of clinicians. I was a medical director, so I saw what admin goes through and what the providers, at the
Love it.
clinics go through. So then I wanted to make the situation better. And one of the first tools that I built was an ambient listening device,
Oh, nice.
and I use it internally for my telehealth company. And now I'm ready to go to market with it too. So I'm kind of here
Okay,
to see the scene. I see a lot of
All right,
competition and everything,
right,
but it's
yeah.
nice. It's something that's really needed. I think a lot of people don't understand it from the patient's perspective as well. So when you're going to a clinician and you're having your visit, if all of a sudden the clinician starts doing this, hold on one second, I'm just taking notes.
Hang on,
It's
Hang on.
right, yeah,
Like,
it's such an awkward
right,
conversation and
yeah.
that connection. But now it's like you start it and you just sit back and you just have an eye-to-eye conversation with the patient. You can actually get to know what's going on with them, build that rapport, and then you can use the computer and the EMR to actually make orders and order labs, order medications, go through their previous results, and tell them things like, "Hey, did you know that 6 months ago your mammograms had to repeat it in 6 months?" And they're like, "Oh, no one ever told me about that." But now because I'm not focusing on typing the notes, I can look at those things, and patients really like it. And usually, when they're done with the visit, they're like, "Oh, you're gonna send my medication?" I'm like, "Yeah, it's already all sent.
Already
It's
done.
all done. It's all
Okay.
taken care of."
Nice.
So I don't have to worry about
Awesome.
typing and everything. So yeah, I use that. I have other clinicians use it, and I think that's gonna change how we practice medicine.
Awesome.
Well,
Very
thank you
cool.
for letting
Thank you
Melissa
for
boss you
helping.
around,
Yep,
helping move
yep,
furniture,
yep.
and we are excited to hear more about what you're up
Thank
to.
you.
Sounds good. Thank you for
Nice
having
to
me. I
meet
really
you.
appreciate
Thank you
it.
so much.
you for
Yeah.
dealing with us.
Thank you.
No worries.
All right.
Thank
next
you.
special guest.
Next special
Oh
guest.
my God.
Here she is.
Kemper Patel
Kemper Patel.
of the Lewis and Clark
Howdy, friends.
Information
I
Exchange.
did not help move furniture, nor was I asked, nor would I have said yes. But here we are. Here we are on the couch.
Here we are.
Yes.
So I'm very
Hello.
excited to talk to Kemper because everybody tells
Loves
me, including
Kemper.
Lisa, that Kemper is the #1 person that they met this year. Who's the best?
That is terrifying. You should not publicly say that. Although,
Listen.
can you give the caveat of when
Okay,
you told
okay,
me
okay,
that?
okay. Kemper is the best. I didn't meet Kemper this year, but I got to know her more this year. It wasn't the first time we ever met, but I would say just like people I got to know really well this year. The competition's been very high. But
Yeah, she
Kemper-
said the competition wasn't high.
Kemper is like
Come on.
head and shoulders.
Lisa is not good at compliments.
I'm not.
That's
Head
why
and
she said
shoulders better than anybody else I got to know this year. It is only
But
October.
mind you, it's on the
There's
ground.
still time.
We're underground on
Right,
your
right, right.
on your like
Right, like,
benchmarks here. So
benchmarks are bad.
you know what? I can look up. It's fine.
Benchmarks are
I
bad.
can do that. But yes, no, it's been great. It's been great to be in this space the last
Yeah.
2 years. It's a crazy world we live in
Yeah.
health IT and
Yeah. Oh,
tech.
boy.
And boy, we're on for a ride, aren't we?
Oh boy,
So
yeah.
listen, what's even going on in Missouri?
A lot of stuff is going on in Missouri.
That's what
Actually,
I hear.
shockingly, Missouri's doing some really cool stuff around interoperability. We're a sleeper state, I think. Like people don't realize, like
Speaking of started from the bottom.
I'm really used to being in.
worst. Is it? There was one point
No.
in time Missouri was the worst state for public health.
It is not anymore. I think.
Amazing.
Do you remember that guy that we had on the
Yes,
talk show
yes.
who was he was freaking crushing it in public health?
This is true.
Yes, actually, public health is one of our greatest partners. They
Well, that
love
is started-
interoperability.
That
Yeah.
is started from the bottom,
Is-
then for
yes,
sure. Like,
yes,
that's a
and public
real-
health is hungry for interoperability, which is really cool. And the state really understands interoperability. There are some really awesome projects going on within Missouri and Kansas. Don't sleep on us in the Midwest, okay?
Yeah.
There is some cool innovation.
Exactly.
I know. We're awakening. We're coming out of the tomb
Midwest.
in the Midwest,
Love
doing some really cool projects. Yeah.
That's great.
Yeah.
Tell us some of them.
Yeah.
What's
Okay.
going on?
I think one of my favorite ones is we're working with the IDD population with the state of Missouri. So the intellect, and for those who don't know what IDD stands for, it's individuals with intellectual and development disabilities. The state manages them. They're generally Medicaid patients their entire life as long as they stay on the waiver. So what we're doing is we're building their care plans electronically and putting them within the health information exchange system. So when a provider, case manager, anyone within their care team interacts with that client, they're going to have their clinical data and their care plan data in the same place. So whether they're interacting with EMS or a doc in the ER or their care manager every year when they do their planning, they're going to have both sides of that person's story to make good decisions with them as they decide how they want to have a productive life
Amazing.
and build toward that. So we're the first state to do it. Missouri's the first state. There's some really innovative, great folks within the state that are pushing this. And so we're the first ones to do it. It's going to go live later next year within a certain, and we're going to grow it.
That's awesome. Yeah, don't snark about Missouri being the
Yeah.
worst state for public health
Please.
if you're me.
We're doing some cool
As me.
stuff.
Lisa, we are taking on similar qualities, and so one of my famous qualities is that I am often wrong, but never in doubt. And Lisa, I feel like you are just doing a great job.
Thank you.
You're taking it on. You're
Doing
taking
a
on
great
this
job.
mantle.
Thank you.
Okay, real question
Yes.
for you. So
Okay.
we have both worked with a lot of HIEs.
Yes. Yes.
And one of the biggest issues that we see is between the states. There's the state
Yes.
and their HIEs. Miriam, we are live on TV.
Miriam,
You got to
you're
go.
on TV
Miriam,
right
go.
now.
Go.
I
Come
love these
back later.
pop-ins. I
Come
love
back
the
later.
pop-ins.
Currently recording.
Jesus
Currently
Christ.
recording.
Okay. Anyway, here we are. Okay. An issue in
Yes.
HIEs
Yes.
is that the state and then their HIEs or just HIE,
Mhm.
there's often a level of not trust. Let's
Yeah.
just say that. So what did you do to have this amazing partnership where you're doing awesome shit and you are not the bottom of the barrel for public health?
No, I mean, I will take zero credit for any of that. Think I just came in at the time to help push it forward. But so we work in Kansas and Missouri. Neither state have a state-run HIE. Both have 4. So we've always had to collaborate within that space. Yes, they do. And
4
Kansas had as a
HIEs.
certification process too. So I have to be
Yep.
certified every 2 years. They were actually one of the reasons why the HIEs in that area exist. They started us, but through high tech dollars back in the day. They pushed it through Kansas. So Kansas at the time, Kansas at the time was being very innovative in health tech and the high tech dollars. They also have a statewide run opt out system. So the state actually manages the opt out, the opting out. So we have to work with them and they push it toward us. So they manage it for the Kansas side, which is really neat. And they kept it all these years. So I think we're just used to working together because we've never been the only one. And on the Missouri side, we are doing a lot of collaborating around building a health data utility within the state and really looking at what that means for Missouri, because every state is different and every state's needs are different, especially if the state's the funder. And that is your client, and we need to meet the needs of that state and help them understand their data better. So I think historically it's been forced collaboration, and then me just being in the space the last couple of years is, okay, there's room for everybody. How do we make this work? And then there's a lot of cultural differences across the state. So not everyone has to be great at everything. We can be good at what we do. And how do we meet in the middle and push that for progress?
I mean, and with the HIE world in general, right? Like, gosh, there's a lot of people who
you've heard of them, right? Have you heard of HIEs?
Them.
Okay, yeah,
like
I knew it's a new thing for you.
A bit stagnant, And I think Kemper is an example of
a non-stagnant person.
A non-stagnant person, somebody who has new ideas, a little bit more energy to move things forward and not be stuck in where things have been in the past. Right. Important is that you're be able to be useful to Missouri and Kansas.
And
like you just said, like, we do what we can do well. You do what you do well. And you're going to collaborate and move forward.
Right. And being open to what that can look like and beyond the last 20 years of interoperability. Like, what's the next 20 years look like? Because interoperability is not going away. It's just changing how it looks and who interacts in that space. So how do HIEs, which sometimes can feel very dusty and like antiquated within the system. But you mentioned trust. We spent a long time building that trust. And then we have all this innovation and health tech coming in. So how do we bridge that trust we have with the innovation that's coming down the pike?
So you said something that I hear a lot, and I would like you to expand on it. What is a health data utility to you, Kemper?
I know. Well, I have read. Oh boy, they were like a health data. So
I'm just like over this term.
I know, and I can take another one. Just give me another term. I'll use it. It's in legislation, so I have to use it.
It is
in Missouri.
I hear that
it's the legal name.
Shout out.
So shout out to HTUs. Big fandom over here. But I think
Kat is your number one fan, health data utility.
But I think the spirit of it could be very interesting and useful. The spirit of moving away from, we have to be the biggest innovators we have to be the most stable, trusted space of interoperability. And how do we translate that for the state, who really has to manage a lot of data to do their jobs and then hopefully do it well? So how do we be a partner in that management with the data movement?
Keep talking.
Yes.
Melissa needs numbers for. Oh, you got
it.
Okay.
Okay.
Oh, boy.
There is action happening off of camera.
Do you have any numbers?
When you're in a live talk show on the internet.
But I think it goes back to HDU, and I know this is annoying when you have to make things personalized per state, but every state's going to manage it differently if they have one, right? And I think that's okay. It's hard to standardize that, but it is what it is because you're dealing within those cultural bounds of each state.
Right. Yeah, totally.
Well, what do you think about you? So you are in one of the states that has multiple HIEs.
Yes. Yes, I am.
You're working with another state that has multiple HIEs.
Yes, I am.
How do you feel about that?
Kill them.
I know. Okay, I get both sides of the argument. I get both sides of the argument.
Just kidding.
I am also pro competition because as someone who's coming into this space new, you see the states that have one, and then you have to see the ones that have multiples. The states have one. That's all they're going to see. And one HIE is one HIE. Technology has changed so much since they started, and some have never updated their technology. They've just bolted things on.
Should we name names?
No, because I like my
Listen, and by the way, just a side note on that. Just to be clear, everything we say here is a joke. This is not a real news show.
Yes.
I'm trying to soften my image.
It's all. This is all a joke. Don't take anything seriously. Fake news. Don't worry about it.
Yes.
We're just joking.
And I'm a big supporter of HIEs.
Names.
We're just joking.
I support HIEs too.
But I think it just depends.
You can never leave well enough alone.
I think it depends, but I think when you only have one.
No, you're fine.
I've seen your show. I'm aware of their show. Yes.
This wasn't.
I was not shocked by this experience at all.
You seem like you're handling it really well.
Well, I told everyone I was a news anchor in 5th grade.
Yeah.
So I prepared for
I
this.
was very
life.
shy in 5th grade. I would not have come
Yeah.
on.
No, I was too. I don't know why
Oh,
that like
man.
lit me up.
You were like,
Yeah, I was like, I'm gonna do that once a week.
Mm.
But I think we need competition in the space, and not to run people out of the road, but to show there's
Yeah,
diversity
for sure.
in what can be done.
Right.
And if you only have one thing, like a utility,
Yeah.
if you have one power company,
Yep.
you have one power company that gets to do whatever they want.
Mm.
And I love electricity, no hate to them. But
Same.
you don't have anything driving that creativity and the growth that needs to be done, especially
Yeah.
in a space that's so freaking innovative,
Yeah.
right?
Yeah.
And
Yep.
so I'm actually a big believer, even though it's really hard to be in a states with multiple HIEs, but at the same time, I think that keeps us moving. And I think you can lose that movement if you don't have that force to
Yeah.
push you.
Yeah, I like it. I like
Yeah.
it. Agree.
Now, are you primarily? How is your funding? Are you primarily state funded, or is it from?
So historically, we were participant funded,
Mm.
and then we, in the last 3-ish years, state is the layer on top of that. So we're
Okay.
participant funded in state. We are still a nonprofit, like most HIEs were created,
Yep.
but our funding model has never been donation driven. It's
Yeah.
always been service driven
Love
or
it.
contract driven,
Mm.
and really interacting with our state actors to help support them and their goals in healthcare.
Yeah. And then you have this Missouri law and potentially
Yeah.
money connected to it, where the state is saying we really want to invest in a health data utility as a state.
Yeah, and
And
there's
that's
some great
unique
folks
about
who understand
Missouri.
it at the state level and really looking to drive how to do the things they have to do as a state better and how to utilize the structures that already exist while innovating at the same time and building on a trust structure.
Yeah. Tell us why a lot of your job is politics.
If anyone's interacted with states, a lot of my job is policy and interacting at that level, because at the end of the day, everything's a relationship, whether it's with a participant or a state actor or even at the federal side, because interoperability is top down, bottom up, and in the space. And the goal is to be connected. So it all has to be connected and those conversations have to be connected. So yes, I interact with policy a lot, because if we look at interoperability as a utility is traditionally supported by states and federal governments, because we know we need it, but one person cannot afford it on their own. So how do we fund that ability to move forward and move the things we need to move while being not eaten by competition that is not going to meet that need or build that trust or have that ingrained nature within the culture that it's in and the state it's in? Because at the end of the day, healthcare is local. Delivery of care is local. There's telehealth. There's some great innovation in that space, but at the end of the day, you're going down the street, right? And that data starts at down the street and then moves.
Yeah. So why are you at Health? This what are you doing here?
Great question. I wandered in and they let me
And
in.
they let you in.
No.
After trading them with lots of US dollars.
drug dogs.
I mean, they were super cute and intimidating.
Yeah.
I was like,
Yeah. Said, "Do
hey,
not
hey
pet."
friends, I will see you from here. I will not touch you, but I do love you.
Did say do not pet.
And I love a
Did say do not
job.
pet.
They're working.
They're working.
And apparently there's therapy dogs in the
What? I missed the
yes.
therapy dogs.
There's
Damn it.
therapy dogs.
Amazing.
And there were wizards.
Yeah.
Not an animal, but there were wizards outside, by the way.
Not an animal.
Just walking. Why am I at Health? Because even though we operate more as a community asset and a utility within the state, I think staying on top of innovation and what folks are talking about within healthcare is really important, so we can position ourselves to know what's going on and to be good partners in the space. We need to be good partners. We don't have to be the first innovators, but we can be the acceptors of innovation and we can be a connector of innovation. So that's why I'm here.
Guys.
Oh, they're just cutting right.
Just
through
cut.
it. Cutting right
Guys,
through it. All right,
it's live show.
Live show, everybody.
Live show, everyone.
Live
Live
show.
show. That's amazing. I would just say if you are looking to partner with an innovative HIE in Missouri or Kansas,
Yes.
Very fun.
very fun.
We try to be.
Great people.
We try to
Yeah.
be.
Really good.
Give
We
me a
would
call.
recommend Lacey.
Yeah.
So.
Thanks, y'all.
You want to tell the internet your phone number?
It is 7155. Just kidding, y'all. What was that commercial that was the phone number?
Yeah.
I cannot say 56829.
555.
But yeah,
Jenny.
they know my phone number if you need it. But just call them and then we can hang. But thank you both. This was a lot of fun.
We adore you.
Continue your marathon.
Again, it's the competition is not
It's
hard.
stiff.
All right. So next up, we have Dr. Neel Shah, who is a medical doctor and is late.
Is he going to give us any medical advice? Probably
You,
not.
okay.
Oh,
All right.
Are we late? or is
Neil,
it-
you
have
know,
the focus?
medical doctor Kavita Patel.
Thank you.
Apparently, we don't know where she's at. So hold on a second while I
Oh,
text
I
her.
love Kavita.
Yeah. Oh, do you keep saying that? Because
I-
Kavita is always late, and I do not love her right now.
yeah,
Yeah, we're
yeah, boom.
just she's not coming. Kat,
Oh, she's not coming?
wait, let it go. If she's not here, it's a live show, guys.
We could do it together.
Okay, why don't you?
Is it a live show?
We are live on the internet currently. It's been streaming the whole time.
Hey, internet.
What's up? Why don't you just introduce yourself for our millions of loyal fans?
Sure. Yeah.
Do that.
No breaks. We have no breaks in the live show.
Yep.
Melissa, is the shot still okay? Is he still okay? Okay. Okay, great. All right, go for it.
I'm Neel.
Great.
My name is Neel Shah. I'm the Chief Medical Officer at Maven Clinic. I'm an OBGYN
Yes.
and a friend of the show.
Friend of the show.
Friend of the show.
We've met you multiple times at
Yes.
various events, various conferences.
Yes.
I think most recently I saw you at JPM last year in one of those kind of disgusting bars that was full of way too many people.
That sounds right.
Yeah, sounds right. It sounds like the JPM experience, basically.
Yeah. More or less. Yeah.
Yeah. So Maven Clinic has been growing a lot. Lots happening.
Yeah.
Tell us where you're at. Like, what's the latest for Maven, and also what are you doing to help?
So Maven Clinic, we're the largest virtual clinic for women and families. We take care of 24 million people in 175 countries, which is wild. It's different from where we started, or even where I started when I came a couple years ago. We take care of people when they're pre-contemplative about starting a family, all the way through whatever path to parenthood is the path that they need, through pregnancy, caring for a kid, all the way to menopause. And right now, all kinds of exciting things are happening, but Maven is really positioned as a platform. So as Chief Medical Officer, one of the things I get to do is look at emerging technologies that we can integrate. And so, the utility of this meeting has evolved for me over the years, but, we spoke earlier on a panel about being priced out of parenthood and talked about the White House announcement last week and got into all the wonky industry related stuff. But the thing that I'm really excited about here is to just go meet with all the other people that are building cool stuff that we can partner with. Yeah.
Yeah.
Very cool.
Let's talk about that, though. I mean, I think the White House announcement was interesting, right?
Always is.
It always is, and I think it was an attempt
Prices you
to
won't believe, I think was the quote.
prices you won't believe.
Prices you won't even believe.
It's obviously only one small part of the journey towards assisted reproductive services stuff is the price of drugs, right? I mean, talk more about the whole, if you were just on this panel or just talking about it, like tell us more about that whole picture. What does it look like today? I feel like in my mind, it's like, I don't know, 20, 30, 40, 50 plus thousands of dollars and huge amounts of time for people. Like it's a very complex process.
The drugs
Drugs are like five out of that. Or
Yeah.
whatever.
All right, let's just start here.
Yeah.
The political moment that we're in right now is best explained by the fact that for a rising generation of Americans, it is harder than they believe it was for their parents.
Sure.
That is true when it comes to people starting a family.
Strong agree.
Yeah,
Yeah.
we agree.
It is more dangerous to start a family than it was a generation ago,
Yep.
objectively. It is less affordable. It is more socially isolating than it used to be.
Mm.
And so the administration's attention to this issue is because of that.
Interesting.
And the announcement last week is a good thing for America because only 3% of Americans can access IVF right now, but the need is
3%?
3%.
Okay, I actually had that's a new number for me.
3% can or 3%
Can act.
3% do, but the waiting line is 5 times longer. So I'm going to also say can.
Wow.
Do and can.
That's a bummer.
Yeah, and
That's a
so
bummer stat.
anything that
Yeah.
we can do to make IVF more accessible, more affordable, more available is good. And drugs make up a third of the cost of IVF. As you all know from being in the plumbing of healthcare, the drug industry has a lot of ways in which they make costs outrageously high and not transparent. So the government used their purchasing power to directly negotiate with the manufacturers, and they meaningfully lowered the prices. They say that in January, the price of a $6,000 per cycle IVF drug will be $3,000 for most people,
Wow.
and that they're going to fast track another medication that could bring it down to $1,800.
Oh, wow.
That's really meaningful. That's thousands of dollars. And they're also making it easier for employers to work with companies like Maven by saying that fertility should look more like vision and dental. be pulled out of major medical.
Like an option thing that you can sign up for.
Well, more that yes, like an option you can sign up for, but more
Because I don't
like-
have to select vision coverage. I
Right.
don't have to select anything, but I don't have to select vision coverage.
True.
I can if I want to.
But to
I
me,
need
it's
to, I have
like
glasses, but
it
yes.
turns out your teeth are important. It turns
Me
out
too.
your eyes are pretty important too, and it turns out reproduction is existential for people. And there are a lot of rules that are set up for diabetes management that don't make sense. Like among the things that I'm now able to do with this guidance is take care of people who are trying to conceive, whether they need IVF or not, and figure out maybe what you need is a $5 thyroid medication or something. I'm allowed to provide $1 coverage. You don't have to meet your deductible necessarily.
Oh, that's great.
So these are meaningful steps, and then obviously there's a very long way to go. But
Yeah, nice.
So Lisa and I both read the preprint.
thank you. It's
Yeah.
you guys and my mom.
Yeah, well, my mom watches our show.
Yeah,
Very
at
good
least maybe a
Very
few
good
others.
fan.
So I remember one thing we initially disagreed on, but then you read it and then you changed your mind because sometimes we are often wrong, but never in doubt. Was you wrote an article on sperm, and Lisa was like, "Oh my God, another man talking about man."
Yeah.
That feels more legitimate. That
I mean,
feels legitimate.
It was
It's a good
something like
take.
that.
Not against
Yeah,
that.
but so that's interesting, and obviously true, right? And everybody should pay attention to it. But how was that your opinion, or is Maven addressing male infertility?
We are addressing it head on. I mean, men are 50% of infertility. Men also independently deserve empathy.
Agree.
Our healthcare
As the mother of two
system-
boys.
Yeah, it's designed by and for men, but men are idiots. We don't use it, and so we live less long. But it turns out men are very curious about their sperm.
I mean, my husband hasn't been to the doctor in like 4 years.
Well, listen,
Not even kidding.
what if I told you that for $40 I could send you a device you can plug into your phone that will check sperm motility, and that men also have a cycle just like women. It's
that
not-
I knew. That one was very clear to
Lisa
me.
is very
That
online,
one
so
was
she
very
did know
clear
that.
to me. I did know that.
and that sperm is probably a better biomarker than cholesterol.
Mm.
I have a patient at Maven who told me his sperm went from a graveyard to a rave, mostly based on not eating donuts.
All
So-
because of no donuts.
Oh,
Processed carbs.
Well, I don't,
Now-
eat, I don't
now-
eat donuts, but I do eat a lot of red
now,
meat.
Yeah, now we're going back into the red meat versus
Okay,
donuts.
we're not gonna do that right now because we're talking about sperm, Lisa. So that's true that it's a better indicator of
You
health
made Melissa
than
laugh
cholesterol.
again.
Melissa,
I
stop
think no.
snorting.
I think it may be a more sensitive biomarker for
Yeah,
metabolic health
for sure.
and for toxic exposures. So it's
Mm,
really hard to quit smoking, but fertility is very motivating.
for sure.
And when you have
For sure.
also cholesterol is boring. It takes 9 months and it's just numbers and letters.
Strong agree.
But imagine seeing your sperm get way more motile, visually after you.
You mean
cut-
like it's a better biofeedback? Like you can. It's a more obvious biofeedback.
in general, yes, and
Yeah.
also for men specifically, it
Sure.
could be not only a pathway into them doing their part for fertility, but also all of primary care.
Yeah,
Mm.
interesting.
That's
Interesting.
very cool.
Okay.
I'm trying to imagine how I would feel about seeing my sperm do that, but I can imagine it would be great. Okay, other things in the preprint.
You'd be curious.
I would be super
You'd be
curious.
like, huh.
To be clear,
How is this?
oh, I love
Okay.
I would go get all these weird longevity things. I'm into it. Other thing in the preprint, you were talking. It was probably last year about Medicaid and taking risk and how to serve that population. What are you guys doing there?
Well, as you may have heard, there's about $1 trillion that have gone missing or will go missing over the
That's
next
what we
decade.
hear.
Yeah, Kavita would be a good person to talk to about that. Um,
If she shows up,
No,
I
no fighting.
Oh,
No fighting.
apparently she's coming.
mean, listen, it's complicated. I mean, even before that, the go-to-market Medicaid was complicated, but we committed to doing it. And there's a lot of conventional wisdom about the average Medicaid recipient that's not correct.
Mm.
Very digitally savvy. And in some ways, these are people who could benefit even more because they tend to be from populations that have less access historically and for other reasons. So our first Medicaid plan almost 4 years ago was actually it was the exchange population in Arkansas. And if you're living in the Delta region of Arkansas and you have gestational diabetes, which there's 1 in 3 odds, you don't need a surgeon like me, you need a nutritionist. And not one that you have to drive out to meet, but one who can look through your phone at your refrigerator and help you plan a meal in real time. And that could be a difference between having your baby on time or having to be induced early and your baby going to the NICU.
Right.
So
Right.
Wow. So, what other areas are you guys working in now with Medicaid?
what areas are we not working in?
I don't know. Tell me more.
I think it's probably a little under a dozen Medicaid plans that we're working in. What's interesting is that I used to see the world in terms of publicly insured and commercially insured. And it turns out the world's much more complicated.
It is.
We also work with Amazon. Amazon has a baby every 18 minutes somewhere.
Wow.
And 80% of Amazonians are fulfillment workers. So a lot of demographic diversity.
Yeah.
We work with labor and trade unions. We work with retail businesses. We work with, an increasingly diverse population. So
Very interesting.
So what's next with like AI and all this stuff? Are you guys even talking about that, or
how can you not? I mean, I think.
I don't know.
Listen, there's.
I'm talking about it.
I think the world will be dichotomized into companies that are AI capable and AI companies that are not. That's like so clear.
But
And
not
so,
from like what they're saying. Like every company in the space is saying something. Are you saying like, are they actually doing it or are they not? Because I think it's
Well-
very easy to say like AI powered, like I plugged in ChatGPT for one thing.
Yeah, I mean, well, we have a demo that we did
Nice.
where we're using agentic capabilities to help with the intake process, but that's equally about the capability itself as it is about the way that human beings, meaning our patients and members, expect to interact with technology companies in 2025 compared to 2024.
Totally.
Like, who even uses traditional search engines anymore in the same way? Like, it's all of us have shifted the way we think. And if you think about even what a user interface needs to look like the agentic guide to the health conference, have you seen it? It's like an avatar woman
I have
that
not.
you can talk to. And what's cool about it is you can have a conversation with her and interact with her the way you would want to figure out where to go to meet you guys, where the art gallery is. But then you can also swipe her away. And like, that's my dream. Like, imagine in real life if I could like talk to people in real life, then just swipe them away.
That's what you would like to do.
It's a better
I
world.
would like to do that.
It's a better world. Yeah.
You would like that more.
I think conversational is probably a hallmark of what's going to come next for what people expect in terms of how to engage.
Yeah.
Like, why can't I just engage in a conversational manner with whatever, with your website, with your
Right.
service, with your
We have to
offering?
be there, right? Because I don't have a waiting room at Maven Clinic.
Right.
I earn the right to make people healthy by engaging them effectively. So I've got to catch up to where the world is. So that's it. And then of course it's all the back end operational efficiency stuff, which is very real. I mean, we're a care management company, but we're also a payer. And there's a lot of things that used to be very manual that no longer are. Or here's another thing that's like blowing my mind as CMO, like purely in the clinical lane. To check the quality of my services, I had to do a random audit of 5% of clinical records,
Sure.
which is the gold standard
Sure,
until
sure.
now, because now we have
Yeah, to pull those
Ambi-
charts.
now we have ambient listening, I
Right.
have transcripts, and I can
Right.
mine them for data even if though they're not structured.
Interesting.
Wow.
Yeah. Exactly. We're thinking about clinical review stuff, and you rightfully need to do multiple layers of self audit before you get to any level of audit, because you have to guarantee that quality.
Exactly.
And so, like, how can you do that now using technology where you couldn't otherwise? which
Now I
think-
can see 100% of records.
Mhm.
Before it was 5%. And like
It's
audit,
very costly to pull
Yeah.
those 5% of records
Very,
manually or whatever
and
else.
so painful. And
Yeah.
like that's the floor QA.
Mm,
The ceiling is like now we're doing like content analyses
nice.
to see what our members need
Sentiment
from us.
analyses, maybe.
Yeah.
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 Nice. very
And
cool.
we're like, are the fertility doctors being used for things that fertility doctors are best positioned to do?
Sure.
And we can answer questions like that.
Nice.
Awesome.
Yeah.
So tell our loyal fans right before, because Dr. Kavita Patel did show up.
Yeah, she did.
She did show up.
We've been talking about her extensively.
Yeah, apparently they're best friends. You two.
She's got, yeah,
Anyway.
they've got a bunch of tough Medicaid questions for you.
Yeah, she's fine. She'll be fine. She'll be fine. She'll be fine. She'll be fine. What would you like to tell our loyal fans, Neil? Before
About-
Millions of loyal fans.
well,
Your
whatever you want to
about
tell 'em.
Maven,
I
about
mean,
why
yeah,
you're here, anything else.
Big,
What's your
big
final
news
words?
for the big
Big
takeaways.
news.
I don't know. I don't know what you guys are doing
You,
with
can tell, you apparently swam across the sea.
I did swim across the sea. I did indeed. Well, okay, here's a real story.
Okay.
I had to go to a doctor, which doctors hate to do.
Yeah.
And I was told that,
Understandable.
medically there are things that I might need to do, but mostly I need to eat better and sleep better and exercise. And then, the way that the incumbent medical system works, it's like, good luck with that.
Yeah.
And
And you decided to swim across the sea.
I got a coach. And if you go around this exhibition hall, you'll find lots and lots of people who are selling services that are seemingly luxury goods because they're sitting on top of the incumbent healthcare system and they're trying to coach you to better health. And my lived experience is that it's not a luxury. It's like the only way to get healthy. Because you need an accountability partner. You need somebody who can like help you do the things outside of knowing that you're supposed to eat better.
Hmm.
So I did, and then I swam across the ocean.
Like,
Wow.
which ocean are we talking about here? Ocean.
Narragansett Bay, so like 2.5.
The
Like,
big one.
let's be
The big
clear
ocean.
about the ocean.
Yeah, it's
Which ocean?
a 2.5 mile swim, but I wanted to do it my.
that's a
2.5
long.
more miles than
That's
I've
yeah.
ever
That's 2.49 miles more than I can swim.
Yeah, so yeah, here we go. That's awesome.
Yeah, I wanted to do it my whole life.
Wow.
And then got some help to be able to do it, and then I did.
Nice.
Very cool.
Congratulations.
Awesome.
Yeah.
So that's your advice. Swim
Yeah.
across the ocean,
Swim
everyone.
across the sea.
Swim across.
Yeah.
the
Nice. Nice.
Awesome. Well, Neel, thank
You
you
two
for
can do
coming
it.
to our
Thank
show.
you,
Yeah,
Neel.
we'll make it happen. We are not each other's accountability partners.
We are not. We are
It's not- we're- we need-
unaccountability
we need a new
partners.
one. It's not good.
Every
But
time we
anyway.
show up at health, we're like, we're not going to drink as much this year. And they're
Yeah.
like, no, just kidding.
Just one
We're going to
more.
drink
But you're
more.
bringing the vibes, which is
We're
good.
bringing the
That's
vibes.
exactly. Yeah, we're great. We are business accountability partners. All right.
That's
Anyway,
right.
we're gonna let you go
Thank
now.
you.
Kavita's gonna
Thanks
show
so
up
much.
here. All right. Thank
All
you,
right,
Neel.
Kavita, you're up.
Hey. Yeah.
You're
No,
up.
no,
Kavita's
she's
not
gonna
up.
hug. She's
We
gonna
are, we're
mush
the
around.
opposite of accountability
Yeah, we
partners.
are the opposite of accountability
Guys,
partners.
she's
So
literally having a
Kavita's
chat.
still
Kavita.
standing here. This is what she does. She's
Hi.
la, la,
Hi,
la.
loyal followers. How are you doing? Just please remember to hit me up so that I can have some more sponsors. Thanks. Bye.
All right. Medical doctor.
Do
Kavita
you want us
Patel.
to have better tech than this?
Yeah,
Then
here we are.
sponsor the
Okay,
show.
all right.
Have
Have
a
a
seat.
Yeah, well, there was
like,
some
sit here,
concern.
Ron,
Melissa
and
was
this is
freaking
mine.
out. That's
gotta
yours.
speak
We
into it
this is a
now.
low budget show,
We only
so
have-
we share.
Boobs
Yeah.
and mics. Okay.
Yeah,
Yeah.
but you know,
Am I supposed to?
you
look?
can do whatever you want to
do
do.
whatever
So
you
Kavita
want.
Patel, Dr. Kavita
Yeah.
Patel is an MSNBC correspondent,
NBC.
contributor.
NBC correspondent. I just
MSNBC.
No,
right?
yeah,
NBC now.
Yeah,
MSNBC
NBC.
separated.
MSNBC. I
They-
said
they-
that.
No,
no, they
NBC.
killed
Oh
MSNBC.
shit! Well, I don't even know what's going on.
NBC.
Yeah.
I don't. Okay. Anyway,
National
Well,
Broadcasting
Peacock.
Corporation.
Yeah, the
Oh.
Peacock. Yeah.
introduce
right.
yourself and all
Sure.
of your activities to our loyal fans.
Oh, one should talk. Okay, right. Many activities. Kavita Patel, friend of the podcast. Friend of
Do you mean the live internet
healthcare-
talk show?
Show.
Yes, I'm gonna
Talk
call,
show.
feel the Cat and Lisa show. Is that Lisa and Cat show? Cat and Lisa, alphabetical.
It's the Cat and Lisa show because Cat is actually the host and I'm just the co-host.
Okay, I was gonna
It's-
do.
yeah,
I start
K&L,
businesses.
Alphabetical.
Yeah,
We're
yeah,
KK.
yeah,
Kavi-
perfect.
yeah. Kavita Patel, internist. I teach classes at Stanford and start businesses in my spare time.
Nice.
Venture partner at New Enterprise Associates, where
Quality.
we spend a lot of money on companies of all sizes and hopefully make some good in healthcare. And in between that, I'm Kat's friend sometimes.
Except for when you're late to the live internet talk show and she's texting you.
I wasn't late.
No. Well, there's some
Melissa
confusion.
Okay,
said
okay,
I
fine,
was-
there was some
Melissa said I was-
All of my friends
Oh.
know that there is often ups and downs in my
No.
personality.
No. Melissa did a great job making sure I got to the right place.
She always
Yeah, you
does.
got here.
So
Yes.
what kind of companies? Like give us some
Yeah,
examples.
what are you
like,
doing here?
What's
What's
going on?
happening?
Yes, everything from starting companies that even Kat's been very helpful with trying to like take former federal workers, CMS, FDA, people who
Sure.
have been reduced in force and bring them together to do consulting. So very kind of traditional consulting, all the way to supply chain technology companies, AI companies, women's health. That's Neel Shah. We're not investors in Maven, but companies like that, radiology.
He says he loves you.
Everybody does until they have to work with me, as you know. So yes.
Then the gauntlet comes down.
Yes, exactly. And because healthcare is so highly regulated, I had a previous life in policy and politics where I
For
met
sure.
some people that you and Kat know. And so spent a lot of time live in DC. So
Yep.
spend a lot of time at the intersection of regulatory, clinical, and technology. That's probably the
Yeah,
best way to
yeah.
describe it.
Where are we right now on the regulatory front?
I actually think this is a great time to be an early stage company
Okay.
because I think there had been a perception, right or wrong, that there would be a lot of like strict regulations that make it hard for people who are not well capitalized.
Mhm.
And I hate that. I hate the idea that you have to be associated with something that rhymes with schmorkel or schmepic or schmamazon
Try.
or yes. I just think that there should be a universe where if you are smart and you have a good idea, and you do need to have like, unfortunately, like all things in life, like to kind of have some luck and connections and a way to
sure.
open doors and not have them close on you. There was this perception that there were too many, and I would argue there are a lot of compliance requirements that frankly patients don't care about and have been created in the benefit of industries like hospitals and incumbents and make it hard. But
right now, from a regulatory standpoint, I think that there is a lot more willingness to not have as much regulatory overhead and allow potentially, but we'll see.
I am
That
pro
has to-
deregulation.
Yeah.
Lisa, how do you feel?
I mean, I feel like I'm definitely pro deregulation for some things.
Yes.
And I think that some of those things should happen. If the government ever opens again, maybe we'll see some of those
that is right.
rules
Yeah.
get finalized or laws
Right.
get passed. I also think that, increasingly, like you said, the cost to the barriers to entry have been whether real or perceived, were quite high.
They're high.
Some of them were real, like $50,000, $100,000
Right.
membership fees
I
for
agree.
organizations. Like that's too much.
That
right?
is.
That's too much.
Right.
And and then there's the perception that you have to like be part of something, or that you have
That
to,
you-
or that
right.
you need to give up, your IP or your ideas to like the really large incumbents. That's concerning for a small company that's
It
just
is.
getting started.
That's right.
And as we say often on the show, even today, best product doesn't always win, but like there's cool innovation and really cool ideas coming from the non-big tech companies.
Absolutely. That's actually at the start of like some of the best tech entrepreneurs
Yeah.
come from someone who like just understood, saw a problem. And I think with healthcare in particular, there hasn't been enough. I'll say it as a physician. Most people kind of discount like what we see on the clinical side because it's not as relevant. Like if you're an ex deep mind person, that somehow is more important. I would argue that like right now, like we're not doing great. Talk to anybody. All three of us have been patients, are patients, and it's not a great experience. So until we can
It's not a great
actually say that what we're doing is incredible and we cannot do better, I think that we should always make room for disruption.
It's just like such a bummer. Like I think most clinicians, physicians, individuals giving care, like care a lot and want to do a good job in there.
Right.
But we're at the place where like the structural issues are overwhelming.
They are.
Even your best intentions as a physician. Like you can run yourself ragged trying to provide amazing care to a whole panel.
And they
Forget it.
do. And that's why the most common LinkedIn, Twitter, Instagram DM I get is
Help me not be a working physician.
how to get out of being a doctor full time. Because they
Are
see
most
me.
of them ER docs?
No, it's I mean, 'cause
feel
since
like
I
it's
know I'm
almost-
primary care,
Ah.
most of them are female primary care, and candidly, like they all like Kat and I have talked about this. We haven't, Lisa. There's this hidden curriculum that like women don't get. So like,
Yeah, women don't have the book.
we don't have the book.
We don't have the book.
By the way, this is
Or the
happening. Like,
network.
I was going to ask you when we're not recording. I need help with like a refinancing on my home, and I've like heard all about these like miraculous like liquid asset lines and all these things that people with a lot of money get assets to. And I said, there's
Secret rich people know.
that's right.
Yeah. This is a
Men.
problem when you're
But-
not born a rich person.
But many,
Lisa didn't even have electricity.
It's true.
so the three of us can commiserate. I don't
water.
have a family member to ask about this. So Kat and I talk to each other about these
For
things.
sure.
So if you're a primary care physician, female, so there haven't been that many women in medicine for that long, then here you are, and you don't know.
Who are you leaning on? Who is your advisor? Who is
There,
your
and then
informal
so many
advisors?
people getting
Yeah.
technology, private people watching, listening, who have been given at this conference. We'll probably get people who say, we'd love to have you as an advisor. And they're going to probably not get that much equity. Do
Yeah.
what you and I did on our very first advising contracts.
Yes, we can talk about this
Secret
often.
talks.
Well, you can too, right? Like so this is the thing. Like none of us came from money,
Right.
We all like did a good job doing stuff, and so got cool jobs. And then people gave us this magical equity word, and then there's all kinds of tricks to maximize it.
Or
remember, you're
non
the company formerly known as Practice Fusion,
non-dilution, like you know.
Yeah, no, I mean, and I think it's really tough. And I'm at the point now where I know I'm missing out on plenty of things, and actually just don't care anymore. Like I've
But you
given up.
can't.
But
Because if that
it's awful.
time you're wasting,
It's awful though.
It
Like,
is
it's
awful to think about it.
It's
right?
a really bad situation, and I have increasingly met more and more women who are
Right.
like, "Oh, let me tell you how to do X, Y, and Z thing." But like that's
I
only
don't
just
know
happening.
if I can
yeah,
have
it's
right.
only just
Yeah.
happening because enough of us
Are getting
fucked
old
up
enough.
and done it again.
Yeah.
Right, right.
And are
And
like getting old enough or whatever.
meanwhile, as
getting
Kat knows, I still cut coupons because there's like a part
I
of me.
don't do that.
There's a part of me that feels like I'll always be poor, and so I still look for discounts.
Well, the great thing about
my
being
husband
born
will
poor,
tell you, like,
I'm
is
cheap.
that
I'm cheap.
I never buy anything that's not on sale.
No,
Oh.
I hate buying things that aren't.
I know, but it's like a big
No,
conversation.
No,
in my
I
household.
genuinely,
No, it's a big conversation
like,
in my household.
I feel
'cause-
very weird about buying something that is full
See,
price.
now she and I are gonna have to be best friends.
That's the kind of thing, though.
Because
she doesn't.
I-
She'll just like
No,
splash
'cause
out.
well, that's because Kat's generous.
I know.
and generous to a fault, a little bit, as
It's
we
true.
know.
That's also
She's
true. That's true.
generous to a
That's true.
fault.
I hear
But
about
I
a lot.
still have this like
Yeah.
even though
Hey,
rationally,
I grew up on Medi-Cal
makes
and
no
on
sense,
food
yeah.
stamps, and I'll
So did
never
I.
forget that. My
Yeah.
entire life,
So,
it shaped who I was.
getting back to the theme, there's so much more technology and
100%.
innovation can do.
Yeah,
We're
yeah.
so for anyone who feeling like, well, that space is dominated or that blank is done.
Got it.
I don't believe that. Like, I just don't believe it. I really
well,
don't. Whether it's
tell us more.
whether it's
Tell us in 1 minute.
electronic health records. I'll give you that as a good example. I don't.
I'm not done yet.
She's not like,
I don't accept that. Like, this is it. I
Yeah.
don't accept it.
Yeah.
I just don't. And
What do
I
you think of
agree.
the
It's
Oracle
it's gonna make me
AI
super
EHR?
popular. I don't. I think that they're doing what they need to do to survive because Cerner is where it's at. But I don't really think this can't be it.
Yeah.
well, I'll give you an example of this really small innovative company, Avon Health, who just like built their own thing. They're in the SMB sort of segment, and they just like built it really quickly, and like
and-
they're super successful. They're doing great work, and they who's
want
starting
the
an
legacy
EHR company
stuff.
in 2025? They are,
That's it though.
and they're doing a good job.
I believe this. This
Yeah.
is it. I don't know. So that's
Yeah.
a good. That's an example.
Which is why I'm pro deregulation generally, because it makes stuff happen a little
I am
faster.
too.
Yeah.
I am too.
Yeah.
And but by the way, same with ICRA, like
Oh,
the
yeah, yeah, yeah,
ability
yeah.
to kind of disrupt the insurance industry. It's a sleeper topic. People are like, what does it stand for? I don't know. If you would say to me, I'm going to
Individual
start a new
coverage and
right, but if you're going to
reimbursement
start a
and
new
something like
insurance
Someone gives you money
company,
so you can buy it yourself.
Yeah,
right?
That's
which,
boom.
That's
but that we should anyway. There's a lot of
Yeah,
spaces.
yeah, yeah.
There's a lot more work that can be done.
So really, so
Yes,
what?
very quickly.
Really quickly, not that quickly.
Uh-huh.
There's a lot of movement around antitrust, not in the way of we're breaking up big companies, but
Right.
we are leveraging
We're right.
laws to bring
Yeah.
legal action,
Correct.
often in states. Like,
Yeah.
tell us what you're looking at there.
Yes.
There's a lot of cases that are moving forward into discovery.
Not just
that-
technology. You mean
not
even
just
like
technology.
with systems
Yeah,
and practices
exactly.
and
So tell us like
hospitals
how
and
you're looking at
M&A
that
and,
kind of
like,
stuff.
So we don't do as many of those deals, but because private equity, there's probably more of that on the private equity
Sure.
side. But I think on the at least just in my like space, it's made it harder to get excited about those deals that are
Yeah.
potentially going to have FTC risk, which is almost everything right
Interesting.
now. So it makes it harder.
Even in this administration, right? There was a really
well
active FTC
because
before,
there seems to
yeah.
be not
continuation a little
doesn't
bit.
seem
or
to
no?
be yeah it doesn't seem like everyone thought Lena Khan would be gone
and then
that
everything
that
would
would
stop.
change
Right.
and it hasn't.
Yeah.
So
We really wanted her to come on our show, but she
Man, I
never-
asked
she
so many
never
times.
responded.
I put out the
Really?
call
I wonder
so many
why.
times. Please. On our world famous show with so many.
Yeah,
which
which,
she,
uh,
like she
listen,
never
listen.
did. She never did.
Yeah.
Okay,
Lena
wait,
Khan.
wait. Before we're done, Medicaid.
What about it?
What do you think about technology companies focusing on Medicaid at this time?
I love it. I think that it's
same.
going to take some capital investment, meaning there's so much like lack of knowledge and uncertainty about Medicaid. So many people think they know what Medicaid is, but they're not seeing what probably both of you see at the very like treetops to grassroots, I think, area. I think it's a
have
great
you seen
time.
companies pulling out because of the potential $1 trillion
Not
hole?
not pulling out. I've seen companies that have had a hard time financing,
Yeah.
and I've seen companies that are doing work for free
Yeah.
on the like cost basis basically, and hoping that like it'll come to them on the back end. I have seen too many people hyping up the 50 billion and thinking
Agree.
that's going to solve
Yeah.
everything. And what we need to do is just
Sounds
accept
like a
that
big number. It's not.
Medicaid is just like a large payer, however you want to phrase it. It's a large population, a large number of payers that are diversified, and it's a great space to be in for that reason. But it's very hard to, I think it's a great time to start a lean Medicaid technology company. But if you're one of the ones that are caught right now needing to get financing and to try to figure out how to like keep people on the payrolls, it's hard.
Right. Strong agree.
It makes sense to have a strategic partner that's well capitalized, whether it's one of the AI companies or one of the Schmorkles or Schmepics or those guys. That could make a lot of sense.
Yeah. Makes
All right.
sense. All right. Well, Kavita, what would you like
Yes.
to tell all of your
Your
adoring
final
fans?
words.
Donate to Zoraya because
Zoria, yeah, did you? Yeah.
I did. I still pronounce it Zoraya. I know Zoria.
I think it's pronounced often Zora, Zoria, Zoraya.
I know
Zoria. It
Zoria.
means
What's the
All right.
problem having weird names like Insana?
I think
health
Insana is.
tech
I think
talk.
Insana is not weird or health tech
Innovaser.
talk.
So many C's, so many N's. Oh my
It's
god.
only so much when you ask Indian
Yeah.
men to name companies. I
That's
don't know.
a situation.
Yeah.
But yeah. Other
Yeah.
than donate to Zoria Foundation.
That's it.
Oh, okay.
All right.
I don't
Listen,
have a lot.
talk show
Listen, do what
fans.
Kavita says.
Talk show fans, do what Kavita says. Also,
Right.
we are done for the day. We'll be back tomorrow at
There you go.
11 Pacific and 1 Pacific
God bless.
from this same location.
Probably.
Probably, we think. We assume. All right. Thank you. Thanks, Melissa.
Bye, everybody.
Thanks, everyone. Bye.